Good morning, everyone. I'm very happy to see everyone here. That's the camera. Okay, thank you. Good morning, good evening, good afternoon. It is a real honor and privilege to be here. My name is Mark Richard Muller. I am the Executive Director of the Academy of Applied Myofunctional Sciences. This is our fourth forum during the 5th Academy of Applied Myofunctional Sciences Congress. We have had 3 others so far, and we have 1 more tomorrow. And we have in our Congress 9 symposia tracks and 120 plus speakers. And the idea behind the fora is to bring together some of these key opinion leaders, key researchers, and some clinicians to talk about issues of key importance. So we have 3 different white papers that we hope will result from this Congress and the learnings that we find here. We've had a couple of offers to publish annals or proceedings of the Congress in some scientific journals in fields that touch our emerging field of medicine, myofunctional therapy. And so the idea was get these people together, get them to meet each other online, virtually. Too bad we can't be meeting in Paris at the beautiful Automobile Club on the Place de la Concorde, or at CRE, the Center for Research and Interdisciplinarity, where we were going to go through exercises like this, which was in my old neighborhood in the Marais. But that amazing institution, CRE, is fantastic. But I'm very grateful. We're going to jump into it here. We have an excellent lineup of key opinion leaders here today. And I'll introduce our moderator, Dr. Phyllis Z, who is a fantastic mentor, wonder to behold and be around. She's, I think, probably makes other keynote speakers at Congresses nervous when I've seen her speak because she's always stellar. But she's president-elect of the World Sleep Society, and she is head of sleep medicine at Northwestern University, Feinberg School of Medicine. And I will hand it over to you, Phyllis.
Mark, thank you very much. And also, Mark has, over several years informally, come up to me and tried to really get me convinced that there is something very special and very important about myofunctional therapy and its role in sleep medicine. So I thought this would be great. Then why don't we have a white paper and try to really look at the data with regards to that. So you know who you are. You are the panelist. And what we're really hoping is with the next slide is to really take a look with the because it's such a multidisciplinary and interdisciplinary group that you're going to come from different perspectives of mainly how do we really kind of get myofunctional therapy into sleep medicine, where when you look at the practice parameters, there may be something about that and say, well, that is one of the recommended therapies for obstructive sleep apnea, whether we're thinking about that in pediatrics, which is where a large amount of the data is in, but also I think there is very likely a very important role in adolescents, but also in adults. So these are our panelists, and thank you everyone for joining us. This is just truly as you can see, international, but also from very, very different points of view and specialties. So here's kind of our goals. We wanted to bring together experts in sleep medicine and myofunctional therapy to explore collaborations for the future along the lines whether we're thinking about clinical research and also education. Of course, it's quite a lot. We hope that we can discuss some of the current state of knowledge from those of you who are really practicing this and doing research in this area, discuss data that exists from basic to clinical studies, and also what are the gaps and opportunities to integrate myofunctional therapy in sleep medicine. Can we prioritize some research areas and opportunities? And then very importantly, what are the resources and partnerships that we need to have to achieve some of these goals? And the idea then eventually is for this group to develop a white paper that's kind of a roadmap for, in these three domains, clinical research and education, as far as how to strategize for the next 5 or so years in this direction. So just for fun, I went to PubMed this morning, and I looked at, I just put in the word myofunctional therapy. And you can see these are the number of publications per year. And what is really interesting to me was that it began really in the 1950s. I mean, there's a couple papers there. But then as you can kind of move along, you can see there's just not too many. Every year it's putts along here with 5 or, papers published in PubMed. There may be many more publications, but as far as PubMed is concerned, it also tells you about the journals that has been published. We can see this very, very strong rise, if you can call it that, around, maybe about the year 2000 or so, and it's kind of go in and out. And at the peak, it was 2019, where you had 35 publications per year. So that's good. That it just really shows that it's really growing. Now, if I go and I go a little deeper and I say, what about orofacial myofunctional therapy, right? Which is what you can see that one, it doesn't really start to be in PubMed until probably in the in the 80s or so. But it drops down to about half of the 30, right? So it looks like half of the 30 is really about orofacial myofunctional therapy. So I think this is, it is not the only way to assess, of course, the impact, the research impact or clinical impact in the field as a whole, but I think it's kind of a measure of where perhaps we need to, or this field could be going. And I think this is a gap, but also an opportunity for more research in that area that is in the public domain, in the published scientific domain. So I'm going to stop here and stop sharing my screen and take it back to Mark, who will continue with some of the presentations.
Thank you very much, Phyllis. Excited to be here. Sorry for the technical difficulties. We have a different technical configuration this morning. So next up on the agenda, Mayor Krieger. Mayor Krieger is known to everyone, editor, Principles and Practice of Sleep Medicine. He was keynote at our Congress, and it is a real honor and privilege to have you here today. Thank you, Mayor.
So what I'm going to cover is what you need to know to establish a new field in medicine, and I'm just going to give you my own personal perspective. So you need a milestone, and the first milestone is a clinical problem. In other words, what is it that we're ultimately going to treat with whatever the therapy is? So milestone number 1 for sleep medicine, in terms of the the embryo of a field, is sleep apnea. And Guilleminault in '73 described something called insomnia with sleep apnea, which didn't really describe what we currently know as sleep apnea, but it was getting close. I did a paper in 1974 that didn't use the term sleep apnea, which really was not used for another couple of years. And for the next 20 years, the conventional wisdom was that we were dealing with a rare disease of middle-aged obese males. So there wasn't a huge amount of activity. So the next milestone was therapy. So we had this rare disease, which was sleep apnea, up to 1981, actually until about 1985, we were doing tracheostomies in these patients. Kingman Sullivan described CPAP in '81, became commercially available in 1985. And it wasn't until then that clinics started to actually evolve, and it became the gold standard, and ultimately other therapies evolved. So these are the number of articles about CPAP, okay? And you'll notice from 1981 until about here, the number of articles wasn't really very, very dramatic. And there were a couple of articles that started to come out from the dental literature on treating sleep apnea. And something happened in 1993. And what happened, and this is milestone number 3, and every field needs this, it needs a shot heard around the world. And the shot heard around the world, if those of you who are interested in American history, refers to the start of the US War of Independence and refers to the first battle at Concord, 1775. So what was this shot heard around the world? It was this article right here in the New England Journal of Medicine by Terry Young and others from Wisconsin, who all of a sudden told us that we were dealing with a really big problem. And up to that point, we really thought we were dealing with something very rare. So, so milestone number 4 is every field needs a champion. And the champion in the sleep field was Bill Dement, who actually started a sleep clinic at Stanford in about 1970, which really dealt with narcolepsy. And that initial clinic actually ultimately failed. And so this is a picture of me and Bill in 2017, but I had met with him in 1985, the same year that Colin Sullivan's CPAP system became commercialized. And I talked to him about the fact, do we need a textbook in this field, in this new field, this evolving field? And this is what he told me, and this really changed my career. He said, you can't have a field without a textbook. In other words, there has to be a body of knowledge. And the other information I got from Bill is you can't simply talk about one disease. You can't talk just about sleep apnea. That sleep is a gigantic, it's something that affects us at every level of our lives, every organ system and so forth. So the challenge was at that time to integrate people involved in sleep into thinking about sleep, getting all the data together and actually coming out with a textbook. And this is a photograph actually of Bill's library, which I took. Bill, as you know, died about 2 months ago. So this is his library, and there's the book that he and I and Tom Roth worked on for about 35 years. So milestone number 5 is coming to grips with the fact that once you have a field, there are questions that a patient, a caregiver, or a referring doctor may ask. What is the therapy? Who is a good candidate? Who will select patients using what criteria? Who will apply the therapy? Who will follow the patient? Will insurance pay for it? And what has the research shown? And so these are all issues that require research. That, you know, we need to do research. So here are my sort of take-home lessons here. Number 1 is that it takes years for a treatment to be established. And, you know, with sleep apnea, you could say it was 15 years, 20 years, you know, we may not even be all the way there yet. It requires innovation. It requires the Colin Sullivans. It requires champions like Bill Dement. It requires case reports, case series, large randomized clinical trials, replication in practice. But the most important thing that it needs is a shot heard around the world. We need to know what we're treating, how big a problem it is, and where are we? We're somewhere around the case series area, and what we need right now is a great deal of science. So I'm going to stop right here.
I just had a question and comment. So I love that you were driving towards a body of knowledge. And actually, last week, I was supposed to be at a retreat at Schloss Biesenstadt, a castle next to Potsdam, not too far from Berlin. And we were going to have some of the people on this panel there, including, we were lucky, there was some good timing with Phyllis Z, and Shannon Sullivan was interested in coming, and we had some other great people who were going to join. But it's great to see balls moving in that direction. And your little arrow that we saw, looking the next step, large-scale randomized controlled trials. We're, as a community, we have an international research consortium for orofacial myofunctional therapy that the World Sleep Society was good enough to give us some space to host a launch for in Vancouver, September of last year. And we have been recruiting sites and training them, University of Oslo, University of Paris, University of Rome, and also we're hoping to get some at Northwestern. So thank you very much. And sorry, pass it back to you, Phyllis.
No, this is great. I think that's where we're at, is the clinical trials. And then we have to think about which population should we start in. Where is that? Where's the cases most advanced in? Should it be in peds? Should it be, you know, in certain populations? And then what kind of clinical settings? But more importantly, where are the outcomes? Is it the AHI? Is it functional outcomes or something else? And I think that we've learned from the sleep apnea literature and also just sleep medicine in general, that perhaps just the AHI is not enough anymore, and that we should be really looking at functional outcomes, whatever they may be, or even better, or in parallel, maybe not better, I would say medical and health outcomes, which I think are going to be really important. And thinking about perhaps some longitudinal studies. They don't even have to be clinical trials. I think you may want to look at following up a cohort of children who have been treated for this and just systematically do a longitudinal cohort study of what happens to them when they become teenagers, what happens to them when they become young adults, and do minimal types of health measures that you could probably get from a doctor's office anyways. It may not be the greatest, but certainly I think that would be another less expensive option.
Your amazing presentation and your contribution. I am always enraptured listening to you speak, but it just so happens that there is a longitudinal study that is going to look at patients who've been watched over a long period of time at University of Oslo with a consortium across Scandinavia that we're really excited to see the results on. To move it along, Daniel Ng, he has become a dear friend over the last few years. He kind of sat me down at the World Sleep Congress in Valencia, Spain 7 years ago and said, how do we go about doing this? And he has worked hard to bring myofunctional therapy into the hospital authority in Hong Kong and touch all the disciplines that we're talking about here today. And it's a real privilege to have you here today, and thank you for your work.
Well, thank you very much, Mark, for inviting me. Good evening, everyone. It's midnight for me, so I'm going to speak in about half an hour to an hour. So excuse me if I sound a bit drowsy. Anyway, I'm a pediatrician, and I'm looking at sleep apnea. One of the problems just highlighted by further is the fact that we do not have an ideal treatment for sleep disorder breathing in children. Okay, we all know that TNA would not solve the problem completely. There will always be some residual sleep disorder breathing, be it AHI being still elevated, snoring that still persists. So I think we need something more. So the other would, of course, would be medical treatment like nasal steroid, montelukast, and sometimes CPAP. Of course, we also know that the orofacial myofunctional therapy here in Hong Kong. So we have basically started the training program here with Mark and Joy. And so it's spreading out in Hong Kong. And I'm also involved in Asia Pediatric Pulmonology Society. And we sort of adopt OMT as an adjunct treatment for sleep disorder breathing in children. But I think the problem is OMT is not a CPAP machine. CPAP machine is pretty standardized. But OMT, what is exactly OMT? It is practitioner dependent, and different practitioners have different programs. So I think it will be very difficult. I think the challenge for OMT would be how to standardize the intervention so it can be carried across different countries and centers to make that one and single standard OMT treatment before we say it's effective or ineffective. Of course, the next thing in my experience is the efficacy versus effectiveness. Okay, because OMT could be very efficacious if it have a good compliance. But in the research done in Hong Kong, we have difficulty in recruiting patients because of a high default rate. So we need to make it more friendly for patients to adhere to our program. Okay, so basically, and of course, OMT would be ideal for children because everything is growing, and OMT has the potential to change the trajectory. So I think that the challenges for all of us and for OMT would be, A, to standardize the training so that to make sure the service delivered is comparable across different sites, independent of or relatively independent of individual practitioner. And second, as Phyllis has mentioned, a long longitudinal study to see whether early intervention in the first, let's say, 6 years of life with trajectory in subsequent adolescent adults. So I think it's work to be done, but it's beginning, is availability in Asia, in Hong Kong, and globally. But we need to make sure we or the practitioner can deliver what's promised in the position statement, white paper, whatever, to deliver the results to the patients. Thank you very much for your attention.
Thank you very much, Daniel.
Yeah, thank you, Daniel. I'm sure, please everyone else speak up, but I really like that focus on, we need to know that everyone speaks the same language as far as what is the best approach and how do you train each of these sites to do it in a comparable manner so that you can compare the results between various centers and various groups. And there goes where Mayor says you need a textbook, but you also need not only a textbook, but you really need, like, how do you do it? Just like the guidelines, right? What are those guidelines? You do this, that, and you can deviate a little bit here and there, but I think that is crucial. You can't do a study without that fundamental aspect. So Daniel, very, very well said.
Dr. Shannon Sullivan, who is a powerhouse. She is a pediatric pulmonologist and sleep specialist. She's so passionate about impacting the lives of children in a positive fashion. She wants to carry on, do research. She's going to start even a master's degree in epidemiology at Oxford, while continuing to maintain a presence in the Stanford orbit. Shannon, Dr. Shannon Sullivan, has some slides here. She's sharing her screen. It's been such a wonderful privilege to get to know you over the last couple of years.
Well, thank you, Phyllis and Mark, for including me. I think I'm delighted to be here. So I just have a couple of remarks, and I think you'll see some of these are kind of recapitulated from what others have already been saying. So thank you to Mayor and Daniel and Phyllis. The title of this session had 2 questions in it. One was, has myofunctional therapy arrived? And the second one was, how may it change the field? So as I thought about a couple slides, I decided to chase those questions a little bit. And the first question is, what does it mean to arrive? In other words, how good does the story need to be to change hearts and minds about adopting a new therapy, or as Mayor said, starting a new field of medicine? And over the course of the AAMS, I think we've heard some really persuasive, powerful stories. But as we proceed, for me, I need to be able to understand the story in terms of the evidence. And so that's where my brain goes. And so as a couple of questions to ask this group, because as a practical matter, being very pragmatic about things, one of the things I started thinking about is how to tie sleep into myofunctional therapy research studies that are already ongoing. Because for me, for example, it's always a mental leap a journey I have to take myself through as I read different studies in sort of nearby fields, making these connections in my head. And I think it would be so great if we had sleep domains already included. So for example, I can read a study about breathing mode, nasal versus oral breathing, and how that changes craniofacial development. And another study about the effect of nasal versus oral breathing on upper airway resistance during sleep. And so I can start to understand how breathing mode changes facial development and structural growth and function, and how that influences sleep. And as you know, you've probably seen this just published retrospective study looking at craniofacial development and male development and oral breathing related to sleep disordered breathing over the long term. So it would be really great on my wish list to start to be able to integrate sleep whenever myofunctional therapy studies are going on, to the extent that we can, because it will add in a small way to a body of evidence. It's not the same thing as large clinical trials, as Phyllis pointed out, but it's a way to be able to start to link together the sleep domain. And this is getting back to this question of, has myofunctional therapy arrived in sleep medicine? And then as Daniel pointed out, and I couldn't agree more, you know, the interventions have to be standardized. And this is tricky. I'm not a myofunctional therapy practitioner, but I can imagine that it's very nuanced, this assessment of each individual and exactly where the dysfunctions are and exactly what the structures are, that there's a lot of nuance and a lot of clinical expertise that comes to the fore when developing a personalized plan. So I think about it like a great marinara sauce or a great pasta sauce, that every cook has you may use the basic same source ingredients, but every cook has their own recipe for really affecting the best product. And then again, you know, marinara can be used in a variety of different dishes. And even the applications of where you decide to put your sauce on what. Is it on, you know, chicken? Is it on pasta? You know, there are some fun comparisons that can be made there. And then I thought about this question, has myofunctional therapy arrived in sleep medicine from a different perspective? And that has to do with reach, because I think it's great for us as a group of kind of passionate individuals pulled together around these ideas and these topics to be able to talk amongst ourselves. But it's another thing to be able to communicate with the professional world at large. And this ties into something that Mara said, which is so important. If you want a field to grow, at some point you're going to need to be able to get recognition for reimbursement. At least in practice in the United States, you know, you need to be able to build that body of evidence, get that recognition so that you can, if these therapies are effective, they can be provided to all patients, not just people who are resourced and can find practitioners to do it. So this is, and this takes time. This is from the task force from the European Respiratory Society on clinical guidelines for the treatment of pediatric sleep apnea. I like this particular paper a lot, and I think Maria Piavilla, who is going to join us today, I'm not sure if she's here, was really instrumental in developing this. But, you know, as has already been pointed out, there's no magic bullet in pediatric sleep disordered breathing. It would be great if we could arrive at a body of literature that was sufficient to be able to start to include or a story, if you like that terminology better, that we could include these therapies in the treatment of these children. So then finally, and I promise I'm almost done, this is just my wish list. Like, what would I love to be able to have to see the field move forward? I think we're still developing testable hypotheses around applications for myofunctional therapy, and really nailing those down and getting starting to get consensus around some of those is very important. As Phyllis mentioned, I think identifying target populations is critical. And I have I have seen myofunctional therapy be successfully applied in all of these populations: adults, middle-aged adults undergoing therapies, surgical and orthodontic interventions for sleep apnea, where long-standing dysfunction exists, young adults who don't really meet the definition for sleep apnea, but are more of an upper airway resistance syndrome phenotype, and then children with a variety of risk factors themselves, either birth risk factors, exposures, structural features, functional deficits that have been identified. Like, this is where we are. We need to identify where do we want to apply these therapies, and what's our hypothesis. And then, you know, development of strong case definitions around those target populations. And again, as Phyllis mentioned, what domains do we want to study? How well, you know, how can we march that out in terms of studies? So do we want to look, I love hearing Kevin's perspective, and I'm glad he's going to be speaking today, because I think starting early in life is very persuasive. If we could start prenatally, that would be fantastic. But breastfeeding and dysfunction that starts early, I think, is a critical area. And quality of life, and you know, what are our outcomes? Is it school and work performance? Is it quality of life? What are the sleep domains? Then finally, I think that I wanted to point out that in terms of randomized clinical studies, which we do need, you know, those are really great at identifying outcomes related to a short-term intervention. And it gets much more difficult when you're in the growth and development space, because the outcomes of interest may not be temporarily related to the intervention in a short period of time. And so really focusing on the longitudinal nature of growth and development is, to me, very important if we want to identify meaningful outcomes. And then we, as already mentioned, standardizing the intervention is impossible, or is very important rather, and very possible. And then the final question was, how can myofunctional therapy change the field of sleep disordered breathing? That was the other question in the title of this session. And I just have 2 quotes. The first is from John Kenneth Galbraith, who is a Canadian and American and academic at Harvard for a long time. And this quote is that, faced with the choice between changing one's mind and proving that there is no need to do so, almost everybody gets busy on the proof. So that there's kind of this natural resistance towards adopting new practices, and we need to be aware of that and be able to gather the evidence to be persuasive. And then the other quote is, the price of doing the same old thing is far higher than the price of change, and so that we need to stay focused on how we can provide value to our patients and to the field. And that's it. I'm going to stop sharing.
That's great. Thank you, Shannon. I think you've kind of outlined the white paper for us already, pretty much all the elements of that. We just have to kind of plug it in, and some of the panel members can each take a little piece of that, and I think you've got it. This is great. Thank you. All right, Mark, I'm sending it back to you.
Thank you. That was so exciting. Shannon has been such a passionate seeker of truth and knowledge, beyond just kind of being in the mix of the clinical community around Stanford School of Medicine and the sleep center there in Redwood City. She took it upon herself to do a research sabbatical to go visit Sapienza, University of Rome, and Maria Pia Villa, where Maria Pia Villa integrated myofunctional therapy into the sleep triage as a first-line treatment at Ospedale Sant'Andrea, the Children's Hospital there. And so, you know, my hat's off to you, Shannon, for your ambition and quest for truth to help little kids. So thank you. And Maria Pia Villa was originally hoping to be a part of this panel. She had something come up last minute in Rome that was urgent she needed to do tonight. So she sends her regrets and her best regards and her enthusiastic support for this work here today. Our next speaker, Dr. Kingman Stroll, he's doesn't need an introduction really. He just got a Lifetime Achievement Award, the American Thoracic Society. I think he's had several Lifetime Achievement Awards, but he's a beloved instructor and leader of fellows in sleep medicine. I know we've got a couple of them on this panel, but Dr. Stroll, thank you for being here today. I'll let you tell part of the story for how you wound up here.
Well, Mark, thank you. I think the Denise Dewald is one of our fellows that came into the sleep program, is now one of our research fellows, and has reinvigorated our particular interests in muscles in the upper airway and the mechanical properties of the upper airway as it relates particularly to sleep apnea. And I want to, I mean, I agree with that this is early. I agree that there needs to be at some point some sort of recognition of value that is generalizable beyond one particular center, so that you can show that this is portable and it's expandable. But I want to emphasize one thing that I haven't heard yet, and if I could, I'd show 2 slides if that's possible. So sleep apnea and snoring is a brain event. It starts with sleep. You haven't heard of wake snoring unless you got something wrong with your upper airway. So a lot of the myofunctional therapy has been focused on speech, on swallowing. And so we have to realize that as a brain event in which people are really not terribly informed, that the brain tells the nerves and the muscles in the upper airway and the chest wall and feedback control what to do. And that what's remarkable from our point of view and from looking at my experience in working with animals is that humans do it so poorly. And why they do it so poorly and how common is snoring and how common sleep apnea is, it's a loss of the functional integrity of keeping an airway patent, which in other species, except for those that have to have apneas, like an elephant seal, they breathe quite well during sleep, thank you very much. So why do we do it so poorly? So you have to realize this is a controller, that is the upper airway, and that the snoring and the apneas occur in the controlled system, and they have to be worked together and in synchrony to not snore or have a healthy airway during sleep. That there is a bidirectional coordination of activity, which is results in disease. And I think pediatrics is really the first place to focus on, because it is you don't have as much mischief happening in the pediatric population as you do in the adult population with smoke, aging, etc. Second thing is the pathways for OSA treatments. So you have to go to sleep. You got to worry about the anatomy. You got to worry about the gain of the respiratory control system. You have to work at upper airway recruitment, and you have sleep-wake thresholds. And the muscles certainly come into play in terms of the anatomy, although apneas often occur in the absence of EMG activity. So we have to learn more about muscle length, tension, its orientation, how it keeps the structures open. And then the other is the recruitment, which is the central nervous system and its coordination, which we think there is a coordinating center in the brainstem that is responsible for maintaining an open airway during sleep. And I think Denise has been looking into this and thinking about this. And this is a time for a lot of literature searches and a lot of thinking from an evolutionary point of view of what happens to then cause this dysfunction. So those are sorts of my thoughts as to how we add this to it.
Thanks. This is great, Kingman. Thank you so much. I love the fact that sleep apnea is a brain disorder. I like that.
Oh yeah, you can make a choice. You can say don't.
No, I love it. This is great. Thank you so much. Back to Mark. We're going to need to move it along.
It's a real honor to introduce Denise Dewald, who won a Chrysalis Award last night at our gala, or yesterday morning if it were in the California time zone. All the time zones, I don't know, this is quite the circadian rhythm thing, Phyllis. I know you travel a lot, but I feel like just sitting here in my house, I'm traveling. But Denise, she can tell her story. I think she tells it so effectively. But I just want to thank Dr. Stroll for taking a chance on a fellow who was passionate, maybe a little bit outside the box, a pediatrician who thought myofunctional therapy was really important to study and move further along in medicine. So thank you so much, Kingman. Denise, it's an honor to have you next here on the panel. Thank you.
Thank you, Mark. Thank you, everyone, for having me. So I'll just give you the background quickly. I'm dual board certified in internal medicine and pediatrics. And when my youngest daughter was 19 months, she had an ALTI, a parent life-threatening event. And it turned out that she had sleep apnea, severe sleep apnea. And her pediatrician didn't recognize it. And I was exhausted. I turned out to have sleep apnea as well. And my sleep apnea wasn't recognized as either. And so I went through the whole dental sleep medicine stuff. I went through myofunctional therapy. I trained in it. And I started developing my own exercises, doing my own research as I was working part-time as a primary care doctor. And decided that I really need to go into sleep medicine to understand this better and to move the field further. So one of my biggest issues with myofunctional therapy that we need to figure out is to figure out which exercises are actually the most important ones and which ones are going to be the ones that we need to be focusing on for the kids to be spending time on that. Because I have the two kids trying to do myofunctional therapy. If they were to be compliant, I'd have to quit my job, So it's too hard in the current state to expect a good level of compliance. So we need to streamline it, and we need to understand which exercises are really important and which ones we can just let, be an optional one. So I want to share this one slide from a study that I think is absolutely critical. This was published back in 2015. It was a functional MRI study done looking to see really if there was damage, cerebrovascular damage in young men with sleep apnea. And so they had them dry swallow in the MRI scanner. They had 12 subjects with OSA and 10 controls. And they found this very interesting change in them, in that the control subjects, when they dry swallowed, all lit up their nucleus ambiguus in the brainstem. And as a reminder, the nucleus ambiguus has the motor cell bodies of cranial nerves 9 and 10. So the glossopharyngeal nerve and the vagus nerve. And in people with sleep apnea, these were young men, it wasn't lighting up when they swallowed. They were swallowing differently. And this, I think, is one of the most critical pieces of scientific evidence that we have for myofunctional therapy. We need to understand what's happening here and how to turn this nucleus ambiguous back on, because the nucleus ambiguous is what's controlling the muscles of the upper airway. So this, I think, is really, really important, and we need to understand how to do this. And so understanding that is critical. And then the other thing, as someone now, as a practitioner, finding myofunctional therapists is a huge problem. In Cleveland, there's one myofunctional therapist. I think that COVID is actually may be making this better for us because we have to introduce telemedicine. And so figuring out telemedicine networks that we can refer to for treating people and for starting clinical trials, I think is going to be really important for moving the field forward and then improve the science. We need it. We didn't be respectful of people's time and give them effective therapy. All right.
Denise, thank you. Fantastic. And I'm so glad. Kingman, thank you for bringing her into our sleep medicine world. Thank you. I would have wanted to do that. I tried, but thank you. I'm so glad you stayed in, and this is really, really fabulous. So Thank you for your perspective, and love your passion for this field. So next I want to introduce Alan O'Brien, who is Executive Director of the World Sleep Societies. I think he may want to say a few words. Alan?
Thank you. And just want to go ahead and just share a couple of things about our World Sleep Society, and also just invite you to share your science at a couple of upcoming meetings. And hopefully everybody can see my screen. So again, our mission statement of the World Sleep Society is really to advance sleep health worldwide. It started several years ago, and with the merger of the World Association of Sleep Medicine and the World Sleep Federation. We're governed by 15 people from around the world, represented by individuals and sleep societies. Birgit Hogel is our current president, with, of course, Phil Z, our president-elect. And the first of three opportunities I want to share with you is first, World Sleep Day. This is an awareness activity that's intended to celebrate sleep and really call in action important issues related to sleep and education, social aspects, driving. But we encourage people from around the world to create an event. An event could be talking to the local press. It could be doing a organized 5K. Also could be working with several different local media just to talk about sleep to the general public. And so the next World Sleep Day is on March 12th, 2021. And we encourage you to go to the worldsleepday.org website for press releases. We have media kits, all of the different tools and references that you can go ahead and use. And this year, the co-chairs are Lourdes De La Russo from Washington and Fang Han from Beijing. And so these different activities around the world, take pictures and share them with the colleagues to go ahead and provide different ideas. The second event that I want to share with you is, please go ahead and attend the World Sleep in Brazil. And so our World Sleep Brazil is really an opportunity for you to submit your science, and we encourage the science to be submitted. Of course, with COVID coming up, our timeline may be delayed for about 6 months, but our current timeline is that we'll have our September 2021 meeting in Rio. Plan B, of course, is to push this back 6 months because of COVID to March 2022, with all the different deadlines for submission of science to occur. But I encourage you to submit your science, submit an abstract, but really I encourage you to submit a couple of good symposia to go ahead and talk about the different research in the area. And then the third area that I want to talk about a little bit with all the different societies around the world that are working together is, how can you work together? And so we do have a mentee program, and with mentees, it is something that we strongly encourage for you to get a part of. We currently have now 9 different centers around the world, including at Harvard and Oxford and Stanford, Sydney, and the University of Pennsylvania as our first 5. But in order to become a mentee, or also to let your colleagues know about the mentee program, to go ahead and sign up and learn more. But it's really about a 1-year program that allows people to get more experience in this area. And this is our picture of our first mentee program with the mentees and mentors that was in Vancouver. And I don't want to go ahead and be also forget about the pediatric side of things. The International Pediatric Sleep Association, their next meeting is February 5 and 6, 2021. This will be a virtual meeting because of COVID. Even if there is a vaccine that comes available, it'll still be online. There is still time to submit your science to the pediatric meeting. And so the website Peds Sleep can go ahead and get you more information about submitting science, and we'd welcome your submission to an attendance at the Pediatric Sleep Association meeting, which happens every other year. And so, of course, remember World Sleep as September, and I'll close that and turn it back to Phyllis.
Great, thank you. Thank you, Alan, for highlighting World Sleep as a great venue for this group to present their science. And Mark, I'm taking it back to you.
Okay. Thank you very much, Alan, for coming on. And thank you very much, Phyllis. You've been so wonderful and generous over the years with advice and guidance and strategic input, which has been really amazing. And I'm also very excited to note that World Sleep has been a wonderful forum for the emergence of our field. Going back to my first experience in Valencia, we had about 5 program submissions that touched on myofunctional therapy. Then in Seoul, Korea, 2 years later, 5 years ago, we had about 15. Then in Prague, I think we clocked in somewhere over 40. And we also had a joint meeting between the AAMS and the World Sleep at Prague, which was oversubscribed, and people were standing out in the halls looking to get in. And we had a very well attended full house in Vancouver at World Sleep last year. And World Sleep has been really probably my favorite meeting in the world. And I'm really honored that we have an opportunity now for our 6th AAMS Congress to locate our Congress in conjunction with World Sleep. So we'll have a really exciting lineup. There's an incredible amount of research in Brazil, in our area, and we have people from all over the world who are chomping at the bit to submit. So we'll have a great turnout, and we're really honored to partner with the World Sleep Society and the World Sleep Congress for our 6th AAMS Congress. Now, if I know Phyllis may have another commitment, a lot of these people are juggling meetings for the APSS, the Affiliated Professional Sleep Societies meeting, which is virtual next week. So she may have to slip away and pass on her co-moderating duties to Sharon Keenan, who's waiting in the wings, and myself. But I want to thank you so much, Phyllis, for your tireless work around the world and leadership. Thank you.
Thank you. I really look forward to the proceedings of this workshop, because I think this will be terrific, and you really have that map already, and it'll be a great way of presenting. And maybe the white paper could be a symposium. You can already put that together for World Sleep. So thank you again. It's a pleasure seeing old friends and new friends, and take care. Thank you very much.
Thanks, Phyllis.
Thank you very much, Phyllis. And so thank you very much, Alan. I also want to thank you for your work. Everywhere in the world, you've been such an incredible partner for societies, for leaders, for researchers, for students, and it's a real privilege to see you involved with the Scientific Society.
No, and we appreciate you to basically advance sleep medicine worldwide. So it's great to partner with you.
Thank you. And it's a privilege now to welcome a dear friend and colleague, Dr. Stacy Quo. Stacy won our Lifetime Achievement Award, the Louis Pasteur Award for the advancement of science in medicine through courage and leadership. She was a recipient at our gala yesterday. Stacy, are you there?
Yeah. I'm here, and I just have one slide if I could share my screen. And this very much echoes a lot of what was already said, but I'm just gonna review some of the topics on the slide, and the fact that I think that the disease of OSA, like Phyllis said, is there something else we should measure other than AHI? And there's a dysfunction that precedes a disease, and especially for kids, and I think that was CG's mantra. And the question is, how do we measure the dysfunction? We need metrics that are measurable other than symptoms. So if there's some type of abnormality, how are we going to define what the abnormality is and how are we going to measure it? And when we target early dysfunction, what is the dysfunction that we're looking at? Is it, it would be abnormal breathing, but there's different types of abnormal breathing. So which type of abnormal breathing do we target? I think I focus a lot on mouth breathing because that's what when we tend to see oral discrepancies. But then how do we measure abnormal breathing? And acknowledging that there are difficulties in having a randomized controlled clinical trial for kids, especially if you're thinking about withholding a therapy on a child, and then there's growth involved. So there's always going to be inherent difficulties with that, but I don't think that should preclude anybody from really trying to get data out there. And another topic I wanted to talk about was just myofunctional therapy is kind of a catch-all. Originally that phrase kind of developed out of the orthodontic literature, but I think we may want to define the nomenclature a little bit better, because improvements in breathing and AHI and respiratory markers, they've been published in many bodies of literature, not just the sleep literature, but they've been in sports medicine and physical therapy and rehabilitation literature. And then the question is, what earlier what Denise said, which muscles do you target? Because there's been improvements just targeting oral muscles and nasal muscles, facial muscles, pharyngeal, cervical, lower respiratory musculature, and all of those muscles are involved in the process of breathing. So trying to define it a little bit more, because there's a lot of ambiguity. And as Denise said, there's many exercises and there's online resources for patients. So the question is which exercises and for how long are those exercises enacted before the effect is really sustained? And I think we can look at the rehabilitation literature for muscle dysfunction for guidance in terms of duration of therapy. And some other things I wanted to point out was already mentioned is the difficulty in recruiting therapists. I think the studies that we've done, it's really using the data from one therapist, maybe two therapists, but it's very difficult finding therapists. And in my orthodontic office, I make referrals to myofunctional therapy or speech therapy or physical therapy. I do about 3 or 4 referrals a day. And the one that's local in our community, there's a couple of them, but they're on a wait list. And then that brings me to the last one, is that the difficulty in really executing this, if it's for myofunctional therapy, because I don't think insurance really covers it, is that it's private pay. And so many patients can benefit from it, but there's a problem with reimbursement from medical insurance, and it's definitely not under dental. So that I think that's one of the pitfalls of really having a complete care.
Thank you very much, Stacy.
That's it.
Your work bringing together threads within the greater clinical community in the San Francisco Bay Area and throughout California and throughout the world, your extraordinary partnership with Christian Guilleminault and Casey Lee, and your work at the University of California, San Francisco School of Dentistry, the medical school at Stanford, and your tremendous lectures around the world and prodigious writing and textbook chapters, including in Mayor Krieger's Principles and Practice of Sleep Medicine. And I know the upcoming edition as well. So it's just been so extraordinary to have you engaged in this world. Thank you so much. And now I want to introduce Dr. Silky Weber, who it's been wonderful. She's on our AAMS board. It's been wonderful getting to know her over the years, because beyond being a pediatric ENT and sleep specialist, she is passionate about things that we, myofunctional therapy, absolutely need. Engaging in European Respiratory Society, committees and position papers and statements, really going to key meetings, IPSA, World Sleep. Really, thank you very much for your leadership and for your prodigious work.
Hi, good afternoon. Oh, good afternoon for me. Good morning, good night for you, everybody. Thank you very much. I think it is a very, 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 very nice opportunity, and I'm honored to share with you our Brazilian experience. Brazil is one of the countries that included very early speech language therapies in sleep medicine. And I think as an ENT, we are quite accustomed to the problem of mouth breathing, and that mouth breathing is not only a problem of obstruction. In ENT, I think it has always been a problem that mouth breathing will persist after adenotonsillectomy in quite a lot of children. Myofunctional therapy, I think, had several names that had been denominated in different ways through the years, and has always been a complementary treatment for mouth breathing. I will put out some ideas that I had and that we that we reached when we were studying about myofunctional therapy here. I hope that I can share with you my slides. Everybody put on the question, what would be the role of myofunctional therapy? So I think we have to define if we want to have it as a treatment alone, as a complementary treatment. Can it help for diagnosis? Can it help for screening? There had been done already systematic reviews. The first one did not evaluate quality and strength of evidence. But what everybody pointed out, as we don't have a lot of studies, very heterogeneous populations and very heterogeneous interventions, it is very, very difficult to come to a strong evidence. All these studies had a lot of bias. So we have to improve the studies who are done. Thinking of screening methods or identifying better populations who would benefit. Together with Maria Pia Vila, we were thinking of a short program because it has to be performable very easily and several professionals should be able to perform it, and we have to standardize this. So thinking on it, which population will benefit of it? Just children? Will we focus on children and adults? And we know Osa is not only one disease, but it is a manifestation, it is a combination of signs and symptoms that is linked to several phenotypes. This is why one treatment, one definition does not work. So how will we recognize the phenotype who will benefit more from myofunctional therapy? Will we do when? Which would be the best moment for it? And how long should it last? There were several studies showing that in pediatric population, a combination of tonsillectomy and myofunctional therapy improves outcome. Although most of these studies do not have any longer follow-up. A more longer follow-up was the study of Guillemino, who showed that a combination of adenotonsillectomy, orthodontic treatment, and myofunctional therapy, so 3 lines of treatment in children in a follow-up of 22 to 50 months, those who performed the 3 steps of treatment had a better outcome. And a study performed here in Brazil, just a very small pilot study, showed that only adenotonsillectomy was not enough to improve myofunctional tonus and function. So for the Brazilian Society, there was sent a start point for a recommendation to complete myofunctional therapy 1 month after adenotonsillectomy in children. As I put it out also at the Sleep Congress, the European Respiratory Society pointed out which would be challenges and perspectives in obstructive sleep apnea for future. The topics would be research for epidemiology, for phenotyping, recognizing phenotyping, the underlying mechanism, prognostic implications, and which would be optimal treatment for Osa patients. And I think myofunctional therapy fits in several myotherapy evaluation and therapy. I think we can't forget myofunctional evaluation. This is, I think we have to standardize evaluation before we try to standardize treatment. And I also would like to remind you that we will have the chance to discuss this in Brazil as a symposium mostly, or making some group meetings. So this is what I wanted to share to you.
Thank you very much, Silky. It's so wonderful to have you on our 3rd AAMS board and everything that you bring to this world. It is my sincere pleasure to introduce next Dr. Kevin Boyd, who is also a colleague. He's in our institute, the AOMT, and he was at the founding meeting of the AAMS, and he has stepped forward we helped start 23 scientific societies around the world, the most recent one being in India. And in our little nascent history of about 9 years, and the 24th one will be the International Pediatric Orthodontics Society. So we're going to help bring that into existence, and he will be founding co-president along with Patrice Bergeron from Switzerland. So thank you for your work and your vision and leadership that led to the awarding of the Albert Schweitzer Award yesterday at our gala. Thank you, Kevin. Please join us.
Hey, thank you. Okay, well, my journey actually started out in San Diego in terms of, what was orofacial myofunctional therapy. I was a interim program director for a pediatric dentistry residency at Rady Children's Hospital. So that's where it started. And I just want to, Mark and I talked a little this morning. We thought it would be best to give a pediatric dentistry perspective on my journey. So, and here's where I am now, is that this just got published in the Journal of Clinical Sleep Medicine. And everything that Stacy and everybody else here seems to understand, that it's not just OMT, it's not just orthodontics, it's absolutely not just TNA surgery. These things all have to work together, not necessarily to preclude one intervention over the other, but as adjunctive treatments and accurate, validated assessments of risk. Another thing I'd like to mention, and this is not at all negative about, I thought that was a very useful slide that Phyllis showed about the literature, OMT literature, starting about in the 1950s. And a similar sort of observation was made about when orthodontia actually became something, people got curious that maybe it has medical benefits and it's not just cosmetic. And it was a Mark Ackerman, who's head of ortho at Harvard, I think. And it got published in the Atlantic magazine. And it said, oh yeah, we didn't get curious about that till well after World War II. Well, to Phyllis and Mark, I have compiled so much literature that talks about myofunctional therapy that dates shortly after the end of the war, the Civil War, okay? Orthodontics and myofunctional therapy were being discussed by physicians and dentists. The physicians were then called rhinologists, and before the orthodontic specialty had, became actually a branch of medicine. Some medical schools were actually teaching orthodontics, University of Virginia, in the 20s and 30s. There's lots of literature, but PubMed doesn't pick it up. You do a search term and they take you back to the 50s or maybe the 40s. Well, to anybody here who would like references, and again, these aren't random controlled trials. These are observational trials. They're controlled observational studies, like I think the one Denise mentioned, which is and she called it very powerful evidence. But they're not prospective randomized controlled trials. Those are the least abundant of all research. They're the most powerful, but least abundant. And they are built upon controlled observational studies, pilot studies. So I can encourage us, and I know Phyllis agrees with this as well, and many here do. We must start pooling data and having definite protocols to do this. So anyway, this is where my journey started. I was an interim program director at Rady Children's Hospital, and their brand new pediatric dentistry residency that came from UCLA. And the only thing that Chicago had to do with it is I flew every Tuesday night for over a year, maybe a year and a half. And I would stay there for 4 days and teach. And I had an apartment, and my main person in the world was Dr. Bill Rawlings, a dual boarded orthopedo, but he doesn't really do much orthodontics. In fact, he called it guerrilla pedodontics. He got in the trenches and he was going into the underserved areas and just fixing cavities and trying to prevent them. And he's the only reason I could do, I really kind of got out of academics after that, but it was just so great having him. And he introduced me to something called myofunctional therapy. So we got our residents to visit an office that Joy Muller, one of his offices, and she wasn't there that day. There was somebody else, but that's how it all started for me. Well, after that, and my residents, benefited from it, I couldn't, keep traveling. I had a family and a practice, so I went back to Chicago. And here's kind of what happened to me. The very first thing that happened is, if you look at this right here, I had a kid that when I wasn't practicing full-time in Chicago, that I had worked up for orthodontics. He was maybe 8 or 9 years old. And I started seeing some of these patients, and the mom brought him in and he looked like this. Not exact, this is a rendition, but it's like, oh, you got the orthodontics done. He goes, no, we're back here to see you. We want to do that now. So I said, well, let's update his x-rays. And it's like, oh my God, what is going on? What happened? And she goes, well, we did this thing called myofunctional therapy. So I contacted her and she got me together. There it is. Her name is Carol Mayer. I couldn't find an image of her, but she's a speech and language pathologist who did myofunctional therapy. And then she introduced me to John Kelly, who, I saw on Monday Night Football when the Bears were playing, because he designed these mouth guards, physiologic mouth guards that some of the players slept in because they slept better. And Kristen Miller was Carol's protege, so needed an office to do some patients for her board certification in myofunctional therapy. And she worked for a while, and then she went on her own. So then Lori Fry came to me from Indiana, and she used to come in and see patients. Well, then I'm sitting in Lurie Children's Hospital faculty meeting, and Steve Sheldon sits next to me and recognizes me because John Kelly told him about me and introduced me to Darius Lakhmani, one of his chief attendings, and invited us both to write in a sleep medicine textbook. And then we wrote a protocol introducing myofunctional therapy and what we call non-retractive orthodontics. And we've been doing it for 10 years, haven't published yet. Well, then after Lori left, she sent me Jody Walker. I had met her somewhere else and fully endorsed by Lori. They knew each other. She's still with me. And then this is one of the last things that has happened to me. This paper that Linda D'Onofrio wrote is just something that I think is so important. She's I think physical therapist in Oregon, if I'm not correct, but she's a myofunctional therapist, and pretty much said all kids that don't have diagnosed syndromes, who also have malocclusion traits in the primary dentition starting, maybe even detectable in utero, they must have oral dysfunction, and orophacial myodysfunction. And it's like, yes, I totally agree with that. So that's my story. Is that now I am proposing to Mark that he and I develop an abstract to submit to IPSA that we talk about how we want to create evidence to persuade the American Academy of Pediatric Dentistry first to integrate myofunctional didactic and clinical experiences to pediatric dentists. Not that they have to become myofunctional therapists, but that they have competence so they can at least do validated, competent risk assessment on every single pediatric patient. So that's all I have to say. Thank you so much for this opportunity, Mark and Samantha.
And the Albert Schweitzer Award is for reverence for life. Is my sincere pleasure to bring up now another colleague and friend, Dr. Karen Sproit. We first started engaging a little bit when she was at University of Chicago 7 or 8 years ago. And then at IPSA meetings and World Sleep meetings, she moved to the INSERM, the National Institute of Health of France, I think about 7 years ago. And we've stayed more and more engaged. And she joined the board of the AAMS. And I really look forward to what she has to share. Thank you very much, Karen. And she also was awarded at our gala last night, the Rising Star Award for great promise in advancing medicine, touching myofunctional therapy. Thank you, Karen.
It was fun to do a virtual gala. So I've been listening in to this conference, to several presentations, and I've been listening with the ear of developmental neuropsychologist and researcher in pediatric sleep. So thank you for inviting me for this forum. I've learned a lot, and I learned a lot since I'm not in myofunctional therapy, but last year or the year before at the IPSA conference, I gave a presentation on poor sleep And I'll just briefly summarize it from a pediatric point of view. So sleep is important for growth and development. And so it was actually Christian Villemino who pushed me to write my presentation into this review paper. It's a meta-review of reviews published on sleep. Poor sleep in terms of sleep duration or sleep disordered breathing, poor quality of sleep. And those studies mostly linked it to health. Fewer studies looked at variable or irregular sleep. And then a whole bunch of studies looking at fragmentation of sleep or the timing of sleep, even napping studies or studies focusing on sleepiness, have mostly linked the outcomes of those sleep issues to social, emotional, and behavioral problems. And then in terms of sleep restriction studies and sleep deprivation or sleep loss or extension of sleep, those have mostly been linked to cognition and memory performance. So if I summarize all of these poor, quote unquote, poor sleep studies and their outcomes, you can see there's a moderate effect size, which is really, you know, the full scale of development of a child that is influenced by this poor sleep, whatever way it is defined, from duration to napping to timing. And so while writing up this paper, I was thinking about how we perceive the concept of poor sleep. And so the bulk of studies are on the quantity of sleep, and then another bulk is on the quality of sleep, and then the circadian rhythm, the timing of sleep has moved into the field drastically. But at the same time, each of these components of sleep actually have also their variability due to society, due to the fact that the child is developing. And that is where me, as a developmental neuropsychologist, why I'm so, and I have always been very passionate about it, that we should not only look from a sleep perspective, but we should look at it from that bidirectional perspective and link this sleep to these inter and intra-individual vulnerabilities in development, or the reverse. Look at this moment when certain milestones are not reached, the first word, not swallowing well, difficulties in social interacting. So what is the difficulty, the ADHD? So link it back then to that poor sleep. So that has been my thrive throughout my whole career and my work. And by doing these studies, I've also noticed that we have ignored the importance of this individual need for sleep. And this individual need for sleep that may develop, that may evolve with you through your childhood development. And so that brings me to the brain development and to where I see the role of myofunctional therapy. So as I said, I've listened to many of the presentations, and what I noticed is that myofunctional therapy is like a bridge. So a bridge to many different disciplines and many different expertise that look at it from a one-sided view, from their expertise. So on one side of my slide, you can see that I've always, throughout my entire life, I always looked at development more in a holistic way. And the sensory motor development, also when I did that review, I noticed that it was a little bit ignored. There's not that many research on it. And that's why I think myofunctional therapy really fits in very well. Because if you look on the other side of my slide, you really see the sensory motor cortex, or the somatosensory cortex. And what you see here is the importance of the sensory fields and the input that comes from those sensory fields towards, you know, the thalamocortical projections. And anybody in sleep, when you hear thalamocortical projections, you know stage 2 sleep, the spindles, the vertex waves, you know already the importance of it for sleep, and that it is different during awake state than during a sleep state. So this sensory motor development and the sensory motor dysfunction that you can see, the speech therapist, they will see an apraxia of speech. The physiotherapist will see motor apraxia, the orthodontists, they will see a malocclusion. The sleep specialists will see sleep disordered breathing. So this all brings it back to this very important region in our brain. And as you can see, the proportion of the image shows the relative density of the sensors and the sensitivity. And the sensitivity of the input, you see really that the gums, the teeth, the lips, the face, the nose, the tongue, all of these are very large areas, so very important. And then we just need to think how often we use our mouth, how often we use our tongue, and for what we use our tongue and our mouth and our nose or our craniofacial area. And then if I go back to children and how they develop, everybody that has children will know that they, at the very first beginning in their life, they put everything to their mouth, they explore the world through their mouth. So this area is very important towards the further development of a child and how they experience the world around them in terms of breastfeeding. Successful breastfeeding can make you close to your mom. It has a smell, it has an interaction, attachment, the voice of your mom. So many psychological developmental milestones that you can reach through an important and good sensory motor development. So myofunctional therapy brings for me back the focus on this craniofacial growth and the importance of tongue. And so being a board member, but not only as a board member, also being a neuropsychologist and as a professor here in Belgium, I very early in my career, I got confronted with being Flemish speaking, and we did not have tools, measurements optimal for this child development in the Flemish language. And so we created with a group of people a non-profit organization, and then this one now, I already left Belgium, but right now this is a governmental institute to help us to get to these steps of accreditation of boards, making sure that you have a good professional development, that you have the expertise, that you have qualified professionals, that you have the right tools, measures, and the right spot. And so through these different boards, I do believe that this is the next step for myofunctional therapy. From all the talks that I've heard, bridging many different expertise, but indeed, as we also mentioned today in our talks, a certification, accreditation is important. We need to have good programs. You need to have, a curriculum requirements. You need to make sure that the practice is done through the guidelines, and very likely those white papers will help us in establishing the next steps for this field of myofunctional therapy. So thank you for pulling me into this, Mark, and for being persistent. So I'll give the word back to you now.
Karen, and if anyone amongst this community or this audience has the good fortune to have Karen as a team member or contributor, you'll be very lucky, because you'll get lots of great ideas and advice and vision. I mentioned at the start of this, I was supposed to be with Karen Sproit and Samantha Weaver and Katrina Rogers, another board member, and Phyllis Z, and some other people at Body of Knowledge meeting in Germany at Schloss Biesenstadt just this past week. And it's so wonderful to have this forum, because we're doing some of this work here in road mapping, the white paper, and we have a lot more work to do. And your proposal kind of key, for certification is incredible. We'll have some exciting announcements at our closing ceremony for the Congress on Sunday, the 30th, which will be at 1 p.m. Pacific time. So please check in at our website about that. We will have the announcement of 3 new nonprofit societies, including the International Pediatric Orthodontic Society, as well as a Society for Clinical Competency Accreditation, and another society for academic competency accreditation. So please stay tuned. Now I want to open it up to the panel. If you guys have any comments or inputs, it was amazing to see so many wonderful overlapping and complementary inputs from these professions that are represented from this stellar group of individuals. I appreciate you taking your time and sharing your insight and knowledge. So I want to open it up to the forum.
Thanks, Mark. This is Sharon. I just want to compliment you again on bringing together an august panel of experts to move this whole field forward. It was very important to hear from historical perspective from Meyer and the developmental achievements that were accomplished during that time. There's so much work to be done. I think that this group of people that you've brought together certainly bodes well for very strong positive direction. We have great scientists, great clinicians, great thinkers, great writers. You've got a great team, Mark. So I wish you all the best and look forward to these next steps, which I'm sure will be moving in the right direction. There's so much work to be done. One of the things that we have to do is to convince all of our colleagues that collaboration is the key. We see that evidenced here today. Another important thing that always comes through is to convince people in the clinical world that there is no competition about patients. There is no competition because there are millions still suffering. We heard the importance of starting the timeline as early as possible. And we know that, given the literature that exists around pregnancy and obstructive sleep apnea and other breathing problems. The fact that Kevin is looking from this perspective adds such beauty to this work and such depth. I'm going to stop here because everything is just complimentary, and I just want to echo again my support of your efforts. And I'm very happy to be a part of it. And looking forward to IPSA.
I appreciate your insights. Sharon Keenan was one of the founders of Stanford Sleep Fellowship Program and the School of Sleep at Palo Alto, and she was on our second AAMS board. Sharon, sometimes you've spoken at conferences. I remember at World Sleep in Prague and at World Sleep in Vancouver, you talked about the need to train all the 20,000 or so sleep techs in myofunctional therapy. I was wondering if you could speak about this opportunity.
Well, I mentioned that, Mark, just because it seems like a natural collaboration. Our sleep techs have a long history of reaching out directly to the patients. The formulation of many of the support groups were done by the technologists. And they're highly skilled people with very close connections with the patients. And I think that it's an avenue that needs to be explored. Again, it comes back to the collaborative effort of the work that we're all doing. It reminds me of Shannon's presentation of integrating questions into existing studies that have the perspective of sleep, and also reaching out to our sleep colleagues to integrate questions about breathing and muscle development. I also think that we need to reach out more aggressively to our neurology colleagues because of the beauty of the changes in the system that we see as a result of some of these interventions. So it's just another flavor of reaching out, that this is an existing group of people that is already highly connected and integrated and working in the sleep environment. So I think, again, you can't go wrong with collaboration and reaching out to our very knowledgeable colleagues with a lot of expertise.
Fantastic. I would love to see some inclusion of these points in the white paper. A question from one of the viewers around the world. Dr. Barry Rayfield in New Jersey asks, he'd like to throw it out to the panel, what would the panel think might be good metrics for, one, anatomic distortions of the face and airway. So you may want to jot these down because there are 3 parts. 2, physiological compensations and dysfunctions. And 3, quality of life and behavioral indications. Yes, Kevin.
I'd like to talk about quality of life. Sorry, I guess it doesn't matter what order you wanted those, Barry, but one of the things actually that I have talked with Barry about and what I've discovered is that quality of life, you know, everybody thinks we're talking about the patient, and we are. But when you're dealing with little kids especially, and you've heard me say this before on this forum, what parent can say they have a good quality of life if they have a child or children that doesn't have a good quality of life? So I think we need to break out from the obvious. It's obvious our patients' quality of life, and there are metrics. They're validated metrics for kids. Most of them are above age 8, but there's a couple of really good papers on how to assess quality of life. Kids under 8 years old, we can do that, and I'm just starting to utilize it in my practice and make it a treatment goal to measure this. But the whole, you know, there's so many papers written on not only quality of life on children with obstructive sleep apnea, but the unaffected siblings, the effect on them, and kids with cancer. All of these things have been established, and I think it's just time that we sort of re-engineer it and include, you know, myofunctional disorders and use some of the already established metrics that they've already used for OSA and for cancer, and not just the kid, you know, the unaffected siblings and the entire family, the parents, the moms, the dads. They have QOL of fathers. They have QOL of mothers. There's so many papers out there that I'm just starting to dig into them. So that's all I'll say there.
I couldn't agree more, Kevin. I think it's critical to include a family systems perspective, and that anyone who is affected within that system will see the progression of some adverse effects throughout the entire family. So I think in all of medicine and in psychiatry, many aspects, of course, we need to see from a family systems perspective, not just the patient that gives an opportunity for tremendous healing within that system.
We're wrapping it up here. We're a little bit 15 minutes over our hoped for time. Are there any last comments or inputs from the panelists?
So I'd like to make a comment on, we need to define what normal is and really understand normal. So is normal someone who doesn't have their wisdom teeth and maybe snores but doesn't have sleep apnea? Or is normal someone who's got full set of wisdom teeth, normal occlusion, and doesn't snore? And we need to understand what are they doing differently with their tongue? What are they doing differently with their soft palate? So I don't think we've really defined what normal chewing is and what these normal postures are, because there's so much dysfunction in our controls. And I think we need to really, really focus on what a normal, an ideal is, rather than a normal, an ideal.
Yeah, if I could comment, because it is a matter of semantics, is that, as you know, normal blood pressure, you know, for Americans in 1970 is 120/80, as dictated by the American Heart Association for a defined population. So normal is a normal, it just means average for a given population. Prior to the Industrial Revolution, Denise, as you know this, because you're fascinated with all this stuff, is that what was normal was also optimal for health, because everybody was subjected to a very similar experience, meaning, you know, born and breastfed for 3 years and on demand, and weaned onto hard food, breathe clean air. But now, after cultural industrialization, normal just means average for a given population, for a given trait at a given time. And as you alluded to, it's like, what's optimal for health, right? That's really what you're asking. So I think it's a great goal, and I'm glad you brought it up.
I agree. I would echo exactly what Kevin's saying. Normal is a statistical variable. It does not mean absence of pathology.
And your question around normal and chewing leads me to something we've explored in this Congress, which is nutrition. We had a great keynote from Takashi Ono of Tokyo Medical Dental University, where he talks about the intermittent hypoxia creating not just conditions for mandibular retraction or maxillary retrusion, high narrow palate, but diminished spongiform papilla. You know, so you're going to have different shorter taste buds, which may impact the dietary impulses, wanting to eat more. And we had a great other keynote from Dr. Robert Lustig. This whole question around a nutritional component, or what are we feeding our babies and ourselves as adults? Lack of chewing, purees, sweetened foods, fatty foods, salty foods. So there's so many questions that we need to explore. It's so exciting. Any final comments from panelists before I just thank a couple of sponsors? I would like to thank Dr. Howard Hinden. He was going to come on. He had to jump into another meeting. There's so many other meetings right now around sleep. He's founder of the Foundation for Airway Health, which has an O2 Day, which is looking to create on the second of the 10th month, October 2nd, is looking to create awareness about helping people with sleep apnea. And they want to come up with a campaign, not just on their day of October 2nd, but have a very aggressive campaign to enlist their thousands and thousands of signatories. They have a petition to sign about airway health to also participate in World Sleep Day. So I wanted to share that exciting news. I think it'll bring a lot more attention to World Sleep. And I want to also announce the AAMS is working with a couple of foundations to have a very robust turnout on World Sleep Day in 2021. So we will be twisting arms for all 24 of the societies we will have online by next month to do projects at our respective areas in Japan, in France, in Brazil, in Chile, for screenings in schools and creating awareness and partnering. So we're so excited to develop a robust offering of tools that we hope can make it into the media kit and the download kit. I think last couple of years, World Sleep Day has had like over 1 million downloads, which is fantastic. So thank you, World Sleep Day and World Sleep Society. And I also want to thank the Republic of France, which has come in as a sponsor. They've been very generous in helping facilitate scientific engagement and activity. And I particularly want to acknowledge the Scientific Attache's Office out of the United States French Embassy in Washington, D.C., and their Los Angeles office, and Pascal Loubière, and also the National Director of INSERM, and also the regional office of INSERM regional office that Dr. Karen Sproit is a part of, and where she's leading some great research in France and around the world, has become a supporting sponsor as well for this Congress and scientific meeting. So thank you, INSERM, thank you, Republic of France, for your scientific leadership and support of our work. And thank you for our great panelists. Everybody has pulled so many directions, and you're so wonderful, and we treasure you. So I hope everyone will join us for our next forum, which will be 9 a.m. Pacific time tomorrow. It will be on breath and breathing. Are we approaching a tipping point? You guys may know about a best-selling book by James Nestor that just came out. We have about 14 or 15 speakers at our Congress who are featured in his book. And so we're going to have a lively discussion. There will be journalists attending. It will be live streamed. And we're looking forward to carrying on knowledge. And that will feed into a 2.5-hour live workshop if you're registered for the Congress with Patrick McCune. And maybe we'll find a way to live stream that workshop as well, which will be very exciting. We can push that out to the public because we've had over 500,000 impressions in just a couple of metrics. There are other metrics I haven't even touched. We've been flooded with input and comments from around the world for our 5th Congress, Virtual Reimagined. And we're 1,000 Congress registrants, and we've got more wanting to process. We haven't processed them. We hope they can figure out how to go to the AAMSinfo.org and register themselves because it'll streamline it rather than getting the questions. But we're hoping to get more Congress registrants, and we appreciate the American Academy of Pediatric Dentistry coming in for their support as well, and several other societies, including World Sleep Society. So thank you very much, everyone. And we look forward to seeing you in person soon, and if not, then virtually.
Thanks, Mark. Bye-bye. Bye, everybody.
Everyone.